Welcome. I'm Richard Kennedy, um, and I'm the Bloodborne Virus Programs Lead at AVIL. I'm living with HIV myself, and I use drugs. I inject crystal meth. So I'm speaking to you from Gadigal land, which is the heart of the Eora Nation of the Gadigal people. I pay my respects to all Aboriginal people in the room here today, and the communities we work alongside. This is and always will be Aboriginal land, and sovereignty was never ceded, and I'm really proud to stand as an ally. So World AIDS Day is a time to remember the 41 million people lives lost to HIV/AIDS. Many of them were our friends, families, and our colleagues, and honour the strength of of people living with HIV today. In Australia, we've achieved the lowest transmission rates among people who inject drugs, thanks to community leadership and harm reduction messages such as needle and syringe programs. That success started with community voices, and our voices are the ones which will keep driving the change. So before we start, there's a couple of quick housekeeping things. This webinar is being recorded, but it's only the faces on the screen and myself and the panel that will appear. There's a closed captions are available, which are in English. And we have a question and answer button on the bottom of the screen for questions. And we'll try to get to as many of them possible if time allows. If anybody in the chat room uses derogatory language, they will be removed immediately from the webinar. So today's topic is navigating life as somebody who uses drugs and lives with HIV. Our friends at NEWA started this conversation last week, and we're continuing it today. Despite strong anti-discrimination laws in this country, stigma remains a huge challenge. Too often, people living with HIV who use drugs are totally unfairly judged. Today, we are here to challenge these misconceptions with this amazing panel we have here today. And so I'll just introduce them. I'll let them introduce themselves. Diane, would you like to introduce yourself?
Yeah, sure. Hi, I'm Diane over here at Perth in our land of the Noongar Nation. Um, have to excuse me. I've got a couple of things. I've got a really bad head cold and just had dental work, so I'm a little bit self-conscious of the dental stuff. World AIDS Day to me is more of a celebration day for me because we've got the International Remembrance Day in May. And I'm a bit sad that I've missed out on a lot of celebration having been sick for a few days. But yeah, I'm really happy to be here. And I think any chance where people that um, have injected or is injecting drugs or using drugs and in relation to HIV can speak up is really important to have our voices out there so that people can be educated and learn. So yeah, I'm happy to be here.
Thank you, Diane. I'll just point out that Diane is actually from Western Australia, and we'll go next to Sonia, who is in Queensland. Sonia,
Hi, I'm Sonia. I work for Quiver. We are the peak body who supports people who use drugs and people who inject drugs in Queensland. I'm known as the peer steroid educator. I'm also on the board of Queensland Positive People as a special representatives advisor, and I've been supporting people living with HIV since around about 2023, and just have experienced what stigma within the health system can look like based upon what I've seen and the support that I've offered. So I'm really looking forward today to sharing some of my thoughts and some of the way that we can maybe be doing things a little bit differently and better, having that two sides of the coin.
thanks. So thank you, Sonia, for joining us. And now we go to Joelle. Joelle's from Albury.
Yes, hello everyone. So I'm here in regional New South Wales on Wiradjuri country. Uh, I've been living with HIV since 2010, and identify as a peer. And for me, I've been working in peer-based responses for around a decade. So yeah, I'm just coming here with a kind of a policy hat on, and also that living experience.
Can I
Thanks,
just add, Richard? Sorry, I don't know if I actually said
yes.
because my brain's a bit foggy. That I also identify as a person who has injected drugs, not of recent times, but look, you never say never. So I think that's, it's always that little um, angel or devil, however you like to look at it, on the shoulder saying, yes, maybe today. And I've also been HIV positive since 1986, so 40 years this year. So, yeah, very lucky still to be here.
Yeah, thanks, Dan. I've been living with HIV since 2001. So, yep, we're long-term survivors.
Yeah.
Also, to everyone watching, I'd just like to say, um, I'm so happy that we have these panelists here today because, for a start, they're all good mates of mine, and second, they're all really fierce and opinionated. So it's going to be a really good program today. So we had some questions. First of all, I asked the staff at ABLE, my colleagues, what they would actually like to know because they're not living with HIV, however, they're drug users. And so the first question is from Ellie Morrison, Deputy CEO. And Ellie asks, I would like to know what it's like to navigate the HIV health system as someone who uses drugs. Where you think you're treated differently, have to talk about HIV differently, or behave differently than you think you do if you didn't use drugs? Like, is there a stigma around using drugs that means you can't talk about it with HIV services and clinicians? And how that might that affect your health and well-being? And what would you like to see from HIV service in relation to people who use drugs? Before I ask the panel, I would say from my point of view, yes, I do lie about my drug use. I do not tell clinicians unless I really, really have to. I don't tell my GP because I know with having HIV, there's already enough stigma. Putting drug use on top of it, I know that I will be not denied access to services, but I'll be waiting a very long time. So, Diane, would you like to start on that? Because you were just mentioning before, when you were in hospital.
Yeah, sure. Um, I'm actually on Suboxone as well. So when they look at your medications, they know what your history is going to be about using drugs. I'm a couple of years ago, I went through breast cancer, doing all okay now. But one of the issues was that when I was doing radiation, up on the screen where it's got your information, it had is HIV positive, wear gloves. Now, it was during COVID, so if they just worn gloves, I actually wouldn't have even noticed. But because I had my information up on the screen, not only was it a breach of confidentiality, because when I was getting dressed, the next person's information came up on screen. So that meant whoever was before me could see that information.
Mm.
So I brought it up with the nursing staff and I got to speak to the manager and said, like, one, you were breaching confidentiality, and two, if you were wearing gloves for everybody, that would have been fine. But just because I've got HIV, a bloodborne virus, it wasn't necessary. There's no body fluids when you're having radiation done.
Mhm.
And I will give them their dues. It was at one of the major hospitals over here in Perth that they said he spoke to his manager and said, you're right, we don't need to have that up there for any bloodborne viruses. So that also will include Hep C. And they changed that immediately. So I was very happy about that. The other thing that was on set from that is I said I'd be happy to talk to the staff. And they said, we have to wait till when you finish your treatment. So
Mhm.
when that was done, I thought, oh, was that all words or, and anyway, so
Yeah.
they actually contacted me and I spoke to the staff and they said, oh, there'd probably be about half a dozen people. But in actual fact, the room was full. And I was
Oh.
really happy, to have that.
Mhm.
So whilst it was an issue, I was really happy with the with what the hospital did and changed the information and their policy. So yeah, um, but not everybody has a voice to speak up and is comfortable to do that. So that's why I do it because I have to be, or don't have to be, but I feel that being the voice for people who, it's challenging for them to be able to speak up about being HIV positive.
Yeah, I agree. It is, and as I was saying earlier, the success of how we have been dealing with HIV in Australia. It started with community voices, and it's our voices, our community voices that can change things. But for not everybody, they can feel comfortable in speaking up, because it can always cause more stigma and discrimination. So
Yeah,
congratulations.
yeah,
Sonia, how do you think on this one as well?
Yeah. Not everybody is going to respond to a HIV diagnosis in the same way. Everyone's going
Yeah,
to experience it differently, and so we can't just have a one rule approach, and it can't be assumed that everyone's going to be traumatized. But we do need to understand that some people are, and the impact of that trauma as well is where I think it can sometimes get a little bit lost. And so within experiences that that I've been a part of, that for some women having a HIV diagnosis can actually create a shutting down of any type of sexual pleasure because sex becomes fearful. Sex becomes something which is then dangerous. And so using drugs of whatever type it is that you use to actually bring back some type of healthy sexual functioning, to have that demonized, to have that judged, to have that, I guess, to have a lecture around that, then you're kind of going, well, this is helping me, and you're telling me that it's not. So then the conversation absolutely shuts down. That reduces continuity of care. It diminishes dignity of risk. And it also brings back the term of problematic drug use. Now, when we talk about problematic drug use, we're talking about the person as a problem. So, in place of actually problematizing the person and seeing their use as risky and offering only an abstinence-based conversation, you're going to shut people down. Instead of asking, hey, how are these drugs helping you? What does that slippery slope look like? And actually give effective harm reduction conversations where it allows a person to have that self-compassion and to be vulnerable with a health clinician to actually look at all of their health in place of needing to hide. So I think the kinder and the broader the conversation is without judgment, the better outcomes would be for the person living with HIV.
thank you, Sonia. And as Sonia has just said, we're not just talking about people who inject drugs, we're talking about all people who use all drugs. So it's not just about injecting drugs, whether you're taking pills, whether you're snorting, whatever drugs you're taking, we're talking about. So we're not just,
Mm,
today, we're
mm,
not just focusing on injecting drug users.
mm.
Joel,
However,
how
we
do you
do
feel?
know that you are more
Sorry.
stigmatized if you inject drugs
Oh,
out of the
absolutely.
hierarchy.
Absolutely.
Yeah,
Absolutely. You go
mm,
from a drug user to basically a junkie,
yeah.
very much if you
Mm,
inject drugs.
mm,
I totally
mm,
agree with you there.
mm.
Joel, how do you feel about that subject on accessing um, the HIV health system and medical
Yeah, it's a great question, and I draw from experiences of having to navigate the HIV health system in three different states. So I've lived in Victoria where I was diagnosed.
Mhm.
I've lived in New South Wales where I can't, currently am, but I've also been in Queensland. And so, yeah, there is not, it's different for every state, I have to say. And it's a bit luck of the draw, like in that regard. Like we don't always, have the choice to kind of move interstate if we're not, you know, happy with the service or finding the service difficult to navigate. And so that means like I've also had to start new relationships with GPs, new relationships with HIV specialists, and also at the time around Hep C. When I was in between moving between Victoria and Queensland, and so and that was pre DAAs, and so yeah, I've kind of taken a similar approach that Sonia talked about, where if this doctor is supposed to be making, um, is acting in my best interests, then I need them to like know about what's happening for me. Um, and sometimes that has worked, and like the clinician receives that information really well and they use it in a way that is guided by me. And there's been other times where it has gotten to a point where I, in that relationship, and I find a different practitioner, like if I'm talking about a couple of GPs. But then I think as well, the more time that's gone on, my ability to kind of just let that stigma kind of go by the wayside and like give them a smart little quip back or maybe point out to them that that there could be a better way of like phrasing it or asking a question. And so, so I think my resilience to HIV stigma has changed the longer I've had HIV and the more comfortable I've got with it. I mean, I'll use a very specific example just quickly. When I'm going in to see my HIV specialist at an outpatient clinic at one in a Sydney hospital, because I haven't relocated that service yet to the country. If I don't like, I have to fill out a form, kind of health behaviors and stuff like that, and I talk about it with the nurse, and then go through to the specialist. And so, if I don't bring it up in the conversation, either with the nurse or with the doctor, they will bring it up around like injecting drugs. And then there's like an insistent on testing for Hep C, even though like in some periods I've not been doing the injecting with anyone else. I've been doing it on my own. And so there is no risk of Hep C in that instance. And like trying to like really be firm about like, well, no, it's not necessary. That's actually a waste of healthcare resources. And so then they still slip in the HCV, and then the pathologist sends me an invoice because they've got no record of my antibody test being positive because that happened in Victoria. And so it's like I've then got to call them. And so it's like not only did I not need the test, but you've also caused all this additional headache that I have to follow up, and you have to follow up because you didn't write the right things on the form. And so it's sometimes that way that like that's not necessarily stigma, but it's making me have to deal with complexity in the system that I didn't have to deal with. And I think, so I see the way that it interacts. Often if I get like the registrar, then I'm doing the educating again. And sometimes I'm in the mood for that and sometimes I'm not. And it's interesting that some of the quips that they make, like someone said, had been like pretty low mood and it was really circumstantial and contextual. Like it was pretty normal for someone to have a low mood in given circumstances. And then she said, oh, well, maybe one day you'll find you won't need to use methamphetamine because you won't be depressed anymore. And I was like, what? I was like, what? Like, I only used it once in the last 6 months. Like, I'm not sure what the relationship here is. Yeah.
Exactly. And often we use drugs for pleasure, not because we're depressed as well.
It's like I only ever these days I'm only using for pleasure. Yeah.
Yeah, exactly.
Yeah, Richard, I think that we have a lot of self-stigma as people who use drugs and also people with HIV. Even though I'm very open and very out about it, but you still have those days where, you carry that stigma and the issues to do with, especially from media, to do with HIV. But I think that the stigma has improved, but it's still there and we're still coping with it. And we still have the issues. I mean, I know that even just as a person who worked within harm reduction, and when I was using, all the time, I would wait until staff went home or weren't around before I got my clean equipment, and that's in a place where you know that you're going to be accepted. And I know they'll use, but you still don't want to do it. Well, I still didn't want to do it in front of people. So I think that's still self-stigma, we
Yeah.
carry a lot
mm,
on our shoulders.
mm. And if I could just add one more really quick thing, as well. I think ultimately, if we just reduce the over pathologizing and give us a space to talk about drugs as the whole picture of what's being experienced, and don't make it a shameful add-on, like what Joelle just talked about, like what Diane's talked about, like what Richard's it's not just shameful add-on which needs to be further stigmatized and further judged. If services could hold complexity without panicking, and I think it's the panic of, oh, you've got HIV and now you're using drugs as well, and there's this instant kind of panic. It doesn't allow for a contextual response, and if there is a contextual response, it'll change the way that people who are living with HIV trust in the services being engaged with before things go over the edge and then become another thing that we need to deal with. So, really starting to enact that trust and to trust the person living with HIV. They know their bodies, their mind. We are so over tested and over pathologized. We get it. Give us some context and give us some trust in our ability to talk to you, and then we'll trust you, and then outcomes can actually start to change.
Mm. And also
Thanks.
for people with HIV, it is assumed that you're not going to be adherent to your treatment,
Yeah.
which of course our, um, you know, um, it's not always the case, that just because you use drugs doesn't mean that you're not going to be adherent. So yeah, the trust thing is really important. And when I was using drugs a lot, certainly they were checking up a lot more and asking a lot more questions, if I was, taking my medication every day. Which now, of course, we have the joy that you have the choice that if you want to be on the injection on Cabandia, and so yeah.
Very much so. And I think also there's that the double whammy that people think that people living with HIV are irresponsible and have been reckless. And I would challenge that in the way that most people with HIV are really careful about their health. They take the medications, they have more doctor's visits. Every time they get unwell, they will visit a doctor. And also the same thing as people who use drugs. People who use drugs are sort of classified into this one basket. Well, so many of us who use drugs, people have families, so many people have children, they have full-time jobs, or they work in community care, they balance the whole thing and they're living with HIV. I think actually we're really responsible at organising and looking after our lives. Now, the next
Yeah,
question, as we're
because
talking about discrimination, as I move along, we're halfway
mm,
through, and I'm going to ask Sonia first of all. Aboriginal people are already face discrimination, let alone those living with HIV and use drugs as well. What can we do to make access to health services less stigmatized, non-judgmental, and easier to access? So, Sonia, I know the Aboriginal side, would you like to start on this one?
Um, that's a really big question, and
I know.
I'm I'm not here to answer it, first of all. I just really want to make that clear for everyone in the room. I'm not here to answer, but I'm here to give some understanding. And the first thing that I want to say is please place power in having a yarn.
mm,
Instead of just going straight to the clinical wording, to the pathologizing, actually have a yarn with the person. Maybe think about the space that they're in. Clinical spaces are not always well received, especially for mob who is in regional remote areas. You bring them into a clinical room with you sitting behind the desk and you're in this seat of authority, actually will further push the person away from wanting to actually interact and really talk. Maybe meet them where they're at. It could be, do you have a space within where you're meeting where you can take a step outside in a personal space where they can take their shoes off, they can ground. Having hard conversations about health needs to be honored, needs to be respected and needs to be valued. I'm going to share a really, really quick story, really, really quickly. So I'll just have a yarn myself now. So there was a person in Queensland. I'm not going to give the areas because I in no way want to give any awareness of who this person could be. However, they were living in a remote community in Queensland. It was a young man, became diagnosed with HIV, and then shared that with the community and family. Within 3 months, he had been ostracized. His home had been taken away from him. They took away his car, his dog, and they just stigmatized and shamed. Now, this isn't every community. I'm going to make that really clear as well. I'm not talking about the whole community. This is about one family, but it makes the awareness that it still happens. For this young person, they had to leave their land, their mob, their family, and relocate 6 hours away to another regional town where no one knew them. And so now they're not only living with this stigmatized condition, which is where their internal self-stigma was truly, truly the one guiding factor, but now the fear of engaging with services became so much more real because of the experience from family. And so one thing that needs to change is have a yarn and actually find out where they're at, what's happening for you. And as soon as we start to judge and shame and weaponize their drug use further to further create this fearful, well, you must stay on your meds and you must do this and you must do that. And it becomes a, it, it's like being over monitored and over policed and with more of a punitive response when what we need is a health response. And that health response must come from empathy, kindness, and understanding, and not always meeting people in clinical spaces. You don't know the impact that generational trauma has on that person. You don't know what they're experiencing when they go home. You don't know if they've got anyone to talk to at all. You may be the only person that they get to talk to about their HIV and drug use. And if they become shamed, they get pushed back into the shadows and they stop talking, they keep doing, and then their drug use exacerbates and then they get blamed again. So please, please make space for a yarn and non-judgmental conversations and don't always meet them in a white room because it's not comfortable. Sometimes just being in the open to have a difficult conversation can make such a massive, massive difference to starting to dismantle the current structures that are in place that prevent honesty from us in our way of what we want to communicate, not what you want to hear. Anyway, I'm going to jump off my butter box now and let someone else go.
Thanks, Sonia.
Well, hey,
Diane, living. Sorry, Joe.
I mean, I used to work in an ACON's needle and syringe program, and where it's located in Surrey Hills, we have a lot of Aboriginal clients coming in to pick up equipment, and a lot of heterosexual Aboriginal people coming in. And people always thought it was quite odd that we had such high numbers, when we do our annual needle and syringe program survey, because it was, they were really large compared to other outlets, but also compared to the population. And it's like, well, it's about location and convenience. Two, it's about the nature of the service. So because we're already understand the stigma of HIV, we're going to be non-judgmental about HIV, but we're going to extend that to harm reduction. But also, I need to give props to the people who were running that service, day in, day out, and they were exceptional listeners. They knew how to. They could observe whether a person was up for a yarn or just needed a transactional quick and go. And so what we're seeing here is like non-judgmental. We're showing I'm always willing to listen and not necessarily offer advice unless it's asked for. Um, but also, we're allowing Aboriginal people and Torres Strait Islanders to be self-determined about their preference about where they receive a service. So we weren't shutting the door saying, "Oh no, there's an AMS an Aboriginal medical service down the road. Why aren't you picking up your equipment at
Yeah.
the Redfern Community Health Centre?" Well, the person's just turned up to our service. So, it is about inviting people in where and when they turn up.
And I think also as well, a lot of people don't want to access the Aboriginal Medical Centre because it's yeah,
Mm,
auntie, uncle, brother,
mm.
everyone's going to be there. Everyone's going to know. And Joel, quickly, just had a question coming through to you, Joel. Have you experienced any additional barriers or stigma as a gender diverse person with HIV when accessing services?
Yeah. Because the outpatient clinic I go to is primarily would be gay men, gay cisgendered men. Often they're not really sure how to handle my non-binary, and so like there's kind of like it's recognized on my records, and like they're recognizing it because my Medicare is undetermined is undetermined. So they do put the right gender markers and stuff when they're ordering my pathology tests and stuff, but they're still very much like treating me like a gay man in terms of like assumptions they make about my sexual practices, like who I'm having sex with, and then that kind of extends also to the drug use. Um, uh, uh, I think like I think a bit like the HIV in terms of like I and more so with gender because they them is new for people in terms of a pronoun. Um, yeah, I used to get quite upset that people would misgender me, but then at the same time, like there's no social reference for people before today, and so I'm like, it's about picking battles. Like, does this person know me? Am I going to interact with this person every day, or am I just seeing them once every 6 months, where they say, "Oh, I'm a boring case of HIV because it's not complex." Like literally the specialist will come into the room with the registrar and say, "Oh, it's Joel. They've got a very boring case of HIV. It's very straightforward." And so it's like, yeah, I play around a bit. Like also he used to ask me like, "Are you transitioning?" And I was like, "Where am I transitioning to?
Mhm.
Like, what to?" And so, okay, just checking, just checking. And I was like, okay, like yeah, and so like I just is it worth me trying to like educate them every single time I go into that clinic? Not really. But where I will put my foot down, like I said earlier, is around like I know what my risks are for STIs and Hep C. So when I say I don't need you to do it like a throat swab or an anal swab or a urine sample, I'm telling you why is because I've had no
Mhm.
sex. Like you need to like it's not like, oh, but you might have had just a little bit of casual sex that you don't
Mhm.
remember. And it's like, no, I'm pretty sure I remember. Like maybe old Joel,
Mhm.
younger Joel might not remember all their sexual partners, but yeah, like I'm a stay-at-home, boring,
Yeah, me
middle-aged
too.
person these
Yeah,
days.
yeah,
Yeah.
yeah, me too. I hear you. Mm, mm.
And Diane, I was going to ask you, living in Western Australia, which is, the biggest state in Australia, your state occupies a third of our continent. How is it possible to even access the Aboriginal community, let alone the ones using drugs, and to give them fair access to medical and health services? Is it a huge problem, or what's
Yeah,
happening over
there's a
there?
couple of things I just wanted to backtrack on really quickly. Is
Mhm.
that people with who use drugs, our aim is also to be undetectable, so we are adherent to our medication. And then two, When we were for peer-based harm reduction, which I worked at for 14 and a half years, that when we were up in West Perth, we didn't see a lot of Aboriginal people, in actual fact, very few. But when we moved down to East Perth, where we are now, where we're amongst other services, we see, I think when I was working there, it was over a third of our clients were Aboriginal. And it took a long time for us to build up that relationship, where, people would come in with their head down and mutter, and you kind of assumed that they wanted one meals, until, like now, of like coming in and having conversations, sharing information about family and issues that was happening. But I think a few things is that, we did a couple of projects which involved Aboriginal people where they actually got paid to be part of that conversation. And also when we've done any surveys and that, and we've always had it that people get paid. So it's a good way to get anybody in, whether you're Aboriginal or not, if you're going to get some money. But and to like to work out where you've got some peers that you can educate more so they can go and educate their peers and family and give them more equipment and that. And so we didn't really have so much of a limit because we know that they might be taking a whole bunch of it up to, Port Hedland or somewhere, So it took a long time for those relationships, to be on both sides. But I think when Sonia was saying that, to be like the non-judgmental and open and, have that two-way conversation. With Joel, that over here in WA, we have what's called the M Clinic run by the AIDS Council, by WAC. And that is for men who have sex with men, non-binary, trans people. So it's a good safe space for people to go to and know that I'm not going to be judged and can be very open. So for a big state, everything is kind of really based in Perth with, some of the other health places like, in some of the major towns. But it's a very hard because we're such a big state to be able to cover everywhere as well.
Thanks, Diane. I've got a question from Yvonne, and I'm not sure if any of us can actually answer this because none of us are clinicians. So this is going to have to be from personal experience. So Yvonne, who works at Able, it says, Richard, I'm interested to know if the effects of drugs are different due to interaction with HIV medications. Like what happens with mental health medications and drug use? And this might be a no-brainer. I don't know. Now, as I said, none of us are health professionals, so we can't answer that. But do any of you have any personal experiences with that? Who'd like to go first?
Yeah, I could talk to that. Yeah, when I started, when I was first diagnosed with HIV, there were a few combination drugs on or HIV treatments on that were available that contained a booster drug, and so it was well kind of known, but also kind of talked about that would boost any kind of substances that you were using on top of that. And I was always a little bit annoyed because they never prescribed those ones to me. And so I thought all these other people are getting a little bit of extra bang for their buck, and I am not. But no, no, no. In all seriousness, but boosters are not really used when people are initiating treatment, or for people
Yeah.
like myself who have non-complicated. And that's not to say there aren't still people on boosters, because if you find a HIV combination that works for your HIV and you're happy with the way it's working, then that's it's not my decision around what medications other people take. And so, yeah, some people still find the drugs containing the boosters are the best. That's what they like.
Yeah.
That's their preferred option. Um, when I was, there is an interaction though with like hormone replacement therapy and
Right.
definitely with gender affirming hormone treatments. When I took feminizing hormones, that had a similar boosting effect where, yeah, I had a go on some substances, and I just it affected me in a yeah, my tolerability was kind of lower. Some
Mhm.
of I found it more difficult to regulate my body temperature as they were stimulants. It's those kinds of, yeah, and I wasn't kind of expecting that.
And we are aware that ritonavir is a booster. It's not an HIV medication. It's also in COVID medication as well, but it can increase the effect of drugs for quite a lot. Sonia, I just wanted to ask, I know you do a lot of work with Dr. Tim Petrovsky with the steroid use.
Thank you,
Is there
Richard.
interactions with steroids and HIV medication and recreational drugs at all?
It's I'm really, really glad that you went there because that was one thing that I wanted to, I did want to raise. And, again, just to reiterate, I'm not a GP, I'm not a pharmacist, I'm a social worker, I'm a harm reduction worker. So this is coming not from a place of please don't judge me for the answer, first of all. Um, when when you talk about use of steroids, and people use steroids or hormone replacement for gender affirming care, whenever that comes in, and especially if it's unregulated and it's not prescribed, it's instantly problematic. It is, um, do you know what this will do to your liver, to your kidney, to your heart? And there's all this list of here is all the damaging stuff that it will do. And so instantly, any further conversation is then removed. It's done. It just doesn't get talked about. That is harm inducing in and of itself. So when the use of steroids comes in, maybe have some respect. Like, just all I'm asking for is a little bit of respect. And whether it's regarding steroids, whether it's regarding gender affirming care, whether it's regarding alcohol use, whatever substance it is that you're using, sometimes I feel as though the interactions aren't always the problem. It's the lack of conversation. It's a lack of actually engaging a person enough so that they can feel safe to be free and vulnerable and fully talk about it. Um, as we know, whenever a person living with HIV is prescribed another pharmacological medication, they will always do a contra indication test to see what's going to work. Now that's fantastic. But if you haven't made a safe space for people to talk about their injecting drug use, their other drug use, their alcohol use, their steroid use, you don't know what the interactions are because the conversation isn't happening. Does that make sense?
Mm.
It's very much so. Thank you,
Yeah.
Sonia. I,
Richard, if I can
I've
just
just
weigh in a little bit on
Can I
that
just
point.
ask a question to Sonia before we go on? I've just heard,
Mm.
um, so it's just for Sonia, anabolic steroids, not
Okay.
prednisone as well.
So anabolic steroids falls under performance image enhancing drugs, and that's a really big umbrella term.
Right.
So you've got your anabolic and androgenic steroids, you've got your peptides, you have your
Mm.
SARMs. Prednisone is a prescribed steroid that is used that would be used under the contraindicator, that they could actually see
Yeah.
what that's going to look like. So prednisone, I've not ever known anybody. Now, I could be wrong. I don't know everyone in the whole world, but I've not known anybody who's actually accessed prednisone based upon a underground source. I've never known that to happen, but accessing performance image enhancing drugs, that I have.
Thank you so much. And Diane, you
Yeah,
were just trying to interrupt you then.
that's okay. I just wanted to add a little bit, kind of on what's already been said a little bit. This is why it's so important that we see the same immunologist or GP and not like when I go to the hospital, I will wait that extra time to see the immunologist I want to see because they know the whole picture about you. My HIV is under control. However, I have multiple other health issues, and they need to look at what the interaction with the different medications are. And if you're seeing a new register and that every time you go up, they're not going to know that whole picture and have an understanding, to that. So, as much as possible, I always see my GP, who's a S100 prescriber, been seeing for like 10, 15 years. So
Mhm.
he will automatically look up or say, yep, this will work or that won't work. So, and it's really frustrating because you don't not want to share your story every time you go out to the hospital if you're seeing a new register. And that's where you're not going to be open about your drug use.
Yeah,
Yeah.
exactly.
Mm.
Thank you. And I've just had a message from Andy Heslop, who's the chair of NUA, and he said Liverpool HIV drug checking is very comprehensive, and he's giving the URL there, so we'll put in the chat for people to look at later. Now, also, actually, while we're talking to you, Diane,
Mm.
Emily just asked a question, and I've lost the question now. Is it harder for women to access HIV services than it is for men?
I think in the general HIV services, you can, access obviously, but for specific things for women is very limited, especially here in WA. And even like, because I actually just resigned from WAC as the peer women's worker, I need a bit of a break. So hopefully they will find somebody else. However, that's not that easy to find a woman who's open about their HIV status. Um, Unfortunately, we don't all have the positive women's like they do in Victoria. We'd love to have that in every state would be fantastic. As Bev well knows, I want to try and do it over here. Um, I just find that the women are a lot more guarded overall about their HIV status. And so to find somebody, there's a woman GP at View Street who a lot of people will see because they know that she will be understanding with women and women's issues. But no, I don't think it's that easy for people to know specific issues for women, medical issues, emotional issues, and just living with HIV. And then if you've got the added of using drugs as well, I think women are even less guarded to bring that up.
Mm.
So in short, no.
That's a really good answer as well. And just kind of add on to that, Queensland Positive People have a women's network, and I think that there's two different types of questions here. And number one is having the ability for women to connect with other women with a sense of safety, but then there's also the health networks as well that have a deeper understanding of the hormonal responses that women can 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 experience based upon the HIV diagnosis. So having I don't know a medical professional that's almost a dual therapist of going, okay, so I understand HIV and I understand this, but being so siloed in that HIV services sits over here, and the amount of GPs that you can access that can do your HIV care and your general care are really, really limited. So it's being able to maybe create more S100 prescribers and make it more generalized and make it more normalized and actually make it easier to access and potentially just putting it out there, maybe this can be part of the training that he's actually received. So when doctors come into general practice, they are already S100 prescribers, so we can stop the system being siloed.
Yeah.
Yeah, that's it. Yeah. And actually, Brett asked a question earlier, given the history of treatment for HIV, and I'm presuming he's been in the older areas in the older stream, and the damage that early medications cause, has this changed any of our trust in medications or our clinical advice? I'm not too sure about how to answer that one.
Yeah, I mean, I'm happy
Oh,
to answer
John?
that. Yeah, look, I mean,
Thank you, John.
I think the situation has changed um, quite a lot since those earlier treatments. I guess we were doing a lot of real world experimenting, and
Mhm.
people put their bodies on the line, and they really did. And because of it, we have the newer treatments. Um, and it's left people with impairment, disability, body changes that are permanent, and we have to recognize that those experiences are really real for people because they are challenging to everyday life. Um, I, I think for me, who only was diagnosed when the newer medications were around, but we also did, there was not, we weren't treating early back then. We were still waiting until people's white blood cell count decreased. And so, yeah, there was a point where I had a choice whether or not I wanted to, when the markers came down and the guideline shifted to treating early, I felt like I did have a choice, but I was also ready for treatment. Um,
Mhm.
because I yeah, yeah, I was really ready for it, physically, psychologically, and in terms of just the way that, stigma of not being medicated and interacting with like sexual partners and things like that.
Mhm.
Um, uh, so yeah, it hasn't informed or it hasn't negatively informed the way I think about treatment, but it has thought about the way that I'm going to be living with HIV treatment for my whole life potentially if there's no cure. And so, what might that look like? For me personally, I reduced from 3 drugs to two drug combo
Mhm.
because I thought, well, if my HIV can be controlled by only 2 drugs, then maybe a third drug means that my liver gets like not having that third drug means my liver gets a little bit of a break. Um, yeah, and then the older I get and the more health conditions I get, polypharmacy, which is having to take more than my HIV medication, um,
Mhm.
it really does make an impact. And certainly, I've been in a place where I take 3 pills a day. Maybe it's my mental health, something for mental health, my HIV, and another health condition. But there's certainly times where it's gotten like toward 5 pills, and I go, oh, that's too much, and that's starting to like make me not want to kind of take my treatment. And so, where possible, if there's like a topical version of it, like that's one way that I can take that burden off my liver of polypharmacy. But yeah, I just wanted to also add that kind of angle.
Yeah, thank
Wait
you,
till.
Joel.
Mm.
Sorry, Diane.
Yeah, Joe, wait until you're in the 60s and it's not just, 5. My God, my tablet regime's almost just not like that is my breakfast. For women back in the day, we weren't actually offered trials and treatments because we had, in one hand, they were saying to me, we don't want you to go on the trials in case you fall pregnant and we don't know what the risk is of the medication of mother to baby. And then on the other hand, they were saying like, not to have children. So it's like make up your mind, and it was very confusing. And it was very hard, I think, for women back in the beginning because, and also we didn't have answers. We wanted to know our bodies are different. So does that mean the medication will act differently? Is there, different, you know, yeah, we just didn't have the answers. And I think it's still very hard to, for like women specific issues, whether about medication or anything to do with HIV, that trust took a long time because as a woman with HIV, I wasn't offered as much as what the men were.
Yeah, and as Andrew, my friend Turf Muir just said that access is difficult because there's so many new S100 prescribers out because all the old guards are retiring. I'm not going to talk about HIV and aging in this one because we don't have much time left. and Neil did a very good session on that last week. But yeah, for myself personally, I was diagnosed in 2001, and because my CD4 count was too high, it took me nearly 9 years before I was allowed to have HIV medication, and I actually had to get Kaposi sarcoma, and ended up in the hospital on chemotherapy before they would diagnose me. Now we've only got 5 minutes to go, so any closing remarks, Sonia?
Okay, I really wanted to quickly, I'm just going to touch on a
Yep.
question that you asked very quickly. With the rising use of pills and G in the festival scene amongst queer and bi youth, do you think the awareness around HIV and testing, or are they too scared of the consequences? All I wanted to say is imagine having a pop-up tent for HIV care, self-testing kits at a festival where now you can be a younger person who identifies within the community. You have a safe space to talk because everyone's there, and it actually takes away this stigma and it takes away this secrecy. So let's start meeting people where they're at instead of forcing people to meet the clinicians where they're at. Take the service to the people.
Fantastic. Thank you so much. I love that. I love it. We could all agree. Diane, any closing remarks?
With the testing, yeah, the testing and treatments are out there, so there's no reason for anybody to be left behind, which is the theme for World AIDS Day this year. And testing, you can get the self kits at the pharmacies or have it sent out. I think NAPWA's still doing that. I'm sorry if they're not, but I think they are. Yeah, World AIDS Day is it's been quietened since COVID. So we need to start talking about it again before, and we don't want the numbers rising. We're doing a great job. We don't want it rising, and especially amongst people who use drugs. So, yeah, that's
And amongst our youth, and I would
yeah.
just like to say we would like to note that a certain sovereign nation has decided not to commemorate World AIDS Day today, and we stand by the people of that nation with our love and support. Joel, any closing comments?
Look, I think I, everyone's made such excellent points. Yeah, I think the future of the response is going to be about equity. I think that maybe that we're focusing too much on individual responses and the biomedical approach, and that misses people because HIV is a social condition. Like I didn't get it from myself. I didn't pick it up from the air. Like it involved doing some things with other people, and we need to kind of recognize that. Yeah.
Thank you so much, Joel. Just before we go, I'd like to say thank you all to these incredible panelists. Once again, I said they're great
And thank
mates,
you
not
to
just
you,
love them all.
and
And I
thank
just still want to iterate what we said before, that the success of HIV and where we are today, plus drug use, has become from community voices. We are the community voices. You three are community voices, and it's our voices that will keep driving the change. And I thank you so much for your valid input today. I love you all. So thank you all so much, and we'll say goodbye now. Thank you.
you. It went far too quick.
I
Thanks,
know.
everyone.
Bye.